Okay. Once again, Kris Fredrickson is a licensed independent clinical social worker and practice at the Seattle VA Medical Center in the Geriatric Research, Education and Clinical Center, or GRECC, as well as the Geriatric Primary Care Services. She holds an MSW and certificate in geriatric mental health from University of Washington, and she's worked for 17 years providing assessment, education, and support around issues pertaining to neurocognitive disorders and complicated geriatric health and mental health conditions and psychosocial factors. Her clinical work includes inpatient and outpatient psychiatry services and community mental health, and she's here to talk about an issue that she has great expertise in, and that's elder abuse, neglect, and exploitation in primary care. Welcome, Kris.
Thank you so much. I'm glad we got the technological problems worked out. Go ahead and advance to the next slide. So today we're going to talk about many aspects of elder abuse, neglect, and exploitation. I hope that that you will pick up some valuable information about working with adult protective services, about the types of abuse, neglect, and exploitation that you might encounter, and the risk factors and abuser profiles. Discuss your professional responsibility as mandated reporters, and explain various interventions that might be available to intervene when you suspect abuse, neglect, or exploitation. Next slide.
Kris, we're also getting a request if you could speak up just a little bit louder.
Okay, will do. So what we know about elder abuse is that it's increasing. Between 1 and 2 million Americans age 65 or older have already been injured, exploited, or mistreated by someone who they depend upon. The prevalence of elder abuse is presumed in research right now to be about 10%, including all of the abuse, neglect, and exploitation. A 2010 study found that 47% of participants with dementia had also been mistreated by their caregivers. And of them, nearly 90% experienced psychological abuse, 20% physical abuse, and 30% neglect. So this is a huge problem we have now. Go ahead and advance. 2018 report by the Administration of Aging indicates that by 2040, there will be 80.8 million older persons, about twice the number that we had in 2000. And people age 65 and older currently represent 15.6% of the population, but it's expected to grow exponentially to 21.6% by the year 2040. And because older victims usually have fewer support systems and reserves, any abuse, neglect, exploitation that causes them physical, psychological, or economic harm has the impact of starting a downward spiral that ultimately can lead to loss of independence, complicating illnesses, and even death. So I'm sure some of you have experienced that with patients. Next slide. And this slide here from the Census Bureau in 2013 indicates the growing population with any type of disability at all. And as we just learned, folks with disabilities are abused at higher rates. This is going to continue to be a problem as the population increases. Next slide. So in 2017, the Washington Adult Protective Services experienced a 252% increase in the number of reports. Now, the reports probably increased to some degree because of more education from aging agencies and more education in the medical field to recognize that this is happening, how to spot the signs, and how to make reports. But it also is increasing. And we'll see how that is being affected right now by COVID in a few minutes. 25% of the reports that Washington experienced in 2017, from 2005 to 2017, involved financial exploitation, which in my anecdotal experience is the most often encountered abuse that comes along in the medical profession. And we know that 1 out of every 24 cases is reported. So there's always a lot more going on than we ever know about, and it is incumbent upon us to really become familiar with the signs and ask the questions. Next slide. Next slide. So when we're talking about elder abuse, we're talking about this definition, and most states include a definition that is similar to this. This is the RCW of Washington. Willful action or inaction that inflicts injury, unreasonable confinement, intimidation, or punishment on a vulnerable adult. And the unreasonable confinement was added not too long ago. So they're expanding on the definition of abuse. Also includes sexual abuse, mental abuse, physical abuse, exploitation of a vulnerable adult, and improper use of restraint against a vulnerable adult. That one also was added recently. Next slide. So the question then is, well, who is a vulnerable adult? And the statutes, most of them contain very similar criteria. Vulnerable adults are 60 years of age or older who have a functional inability to care for themselves, or they have found to be incapacitated, meaning that they were determined by a judge that they require a guardian or a fiduciary or something to that effect to manage their affairs. Someone who has a developmental disability, someone who is admitted to a care facility, any kind of a care facility, adult family home, assisted living, nursing home. If they're receiving services from a home health, hospice, or home care agency that's licensed with the state, and those types of facilities I just mentioned are included in that. Or they're receiving services from an individual provider that they pay to come in and help them out in their home. And even if they are self-directing that, they've hired them, they tell them what to do, they don't have an outside agency as a boss, that still can qualify them for vulnerable adult statute. Next slide. So who are at risk for abuse, neglect, and exploitation? The research seems to indicate that women are more at risk, and that I mentioned before, the physically and medically disabled, those diagnosed with a cognitive impairment, neurocognitive disorder, a mental health issue, or substance abuse issue. Those that are socially isolated, live alone, might be unmarried or divorced, no longer living with their former spouse. A person that lives with a caregiver in their own home. So a caregiver is either living there or coming regularly to take care of them in their own home. And that they have a history of previous trauma. So that could be domestic violence, that could be a sexual abuse as a child, past history of violence to them as an adult. There seems to be an ongoing discussion as to whether specific age has more or less risk. And some research says over 65, over 85, and some says not. So that's still being researched, and as more abuse research happens, we'll hopefully get more clarity around that. But we know that folks get more disabled as they get older, so we can assume that older folks are definitely more at risk. Next slide, please. So as we're talking throughout this training, I want you to think about Mrs. A. She is a 92-year-old African-American World War II veteran and divorced for 30 years. She has abundant medical disorders, Alzheimer's disease, arthritis, kidney disease, macular degeneration, falls, and uses a wheelchair. She's had a history of domestic violence with her ex-husband. She now has a son that lives with her. He's 65, and she lived with her dog alone in her house until he moved in. And now he's living with her and helping her with her daily activities and her instrumental daily activities, including managing her money and cooking. She says that she's losing weight because she doesn't very much enjoy the food that her son is making her. And she appears to be unkempt and inappropriately dressed for the weather when she comes in. She comes into the clinic brought by her son, who says that her pain meds need to be fulfilled. So thinking about the risk factors and what we've talked about so far, Mrs. A certainly has a number of risk factors. Next slide.
So Kris, sorry to interrupt. I'm going to turn off your video to see if that helps. The sound quality is not coming through real well. So I'm going to turn off your video to see if that might help a bit.
Okay.
It shouldn't affect anything other than that.
Okay.
Okay.
How's that? Is that better?
It might be better. The key thing I think for you would be making sure you're not covering up any microphones and to speak up a bit.
Okay.
Sorry.
And all right. So when we're talking about this topic, we're talking about various forms of abuse, neglect, and exploitation. But first, I like to address neglect because neglect is the one that we also see very frequently in primary care settings. Three types of neglect. Passive neglect, when the caregiver fails to meet their obligation to provide care. Passive neglect, when the caregiver is unintentionally failing to meet their obligation. And self-neglect, failure to meet their own needs. Some of the indicators of these types of neglect, if a person comes in lacking their own personal care, seeming not to have addressed their basic needs, eating, drinking, having medical needs and health needs that are not addressed. They might show up into the primary care clinic looking disheveled and unkempt like Mrs. A. Some of the things to watch for the perpetrator is if they are reported or the vulnerable adult is reporting that they've been left alone without access to things like food, water, their medications. If they've failed a number of their medical appointments and appointments in the community, if they have unfilled medications for long periods of time and then suddenly they show up and they want them all filled all at once. If the caregiver has abandoned them at the emergency room, and I get this from time to time with very stressed out, burdened caregivers who say, I'm just going to leave them at the emergency room. And I have to explain to that person that that is considered abandonment and that is not the best choice, and figure out what kind of support to provide for them so that doesn't happen. Or if they're living in an unsafe condition, if their roof is leaking, if they have animals, rodents, and bugs in their living situation, if they have mold, other things that make that habitation unsafe. Next slide. Is the sound better?
It's a little bit. It's still, it's not great. So I'm not sure what to say. I have a feeling it's the setup at your room. The trick would be to just unfortunately keep trying to talk up and speak right into the microphone on your system.
I'm in a very quiet space too, so that's interesting. So when we talk about self-neglect, I have gotten this question. If an individual is not found to be legally incompetent, we'll talk about that, incompetence and incapacitation in a few minutes. But if they're not found legally incompetent or incapacitated, but choose to neglect their own personal health or safety, or refuse care, refuse medications, refuse to come into their appointments, refuse to answer the door, is this self-neglect, and is this warranting a report and some kind of intervention if that is possible? The bottom line is yes. If in doubt, report. And it is better to report and be wrong than not report and have it actually be a bad situation. So even if they are self-neglecting, reporting is a good idea. Even if the APS doesn't find anything when they investigate, it creates a paper trail for the future. So if this kind of thing happens again, they can look back and say, oh yeah, this is a pattern now, maybe we need to intervene. Next slide, please. So with physical abuse, this one tends to be picked up in physical exams, emergency rooms, by other family members that are coming to visit. Some of the indicators of the physical abuse, when the patient is with you, they're fearful, they're cowering, they're fearful to talk if their perpetrator is with them. They might have physical signs, bruises and cuts. They might be hypervigilant, have an exaggerated startle, be fearful to be left alone in an exam room, be fearful to be left with their caregiver who has brought them in. They might have old injuries that show up on x-rays and scans. They might have come to the hospital or to the clinic for numerous reports of a similar injury, a wrist being sprained, an ankle being sprained. And the injuries don't necessarily match the story that they tell about how they got it. The perpetrator might not bring the person in when they're injured, or they go to different emergency rooms every time, and you're able to find out that, they were at a different emergency room a couple miles away last month. If the caregiver loved one doesn't disclose a person's injury until it's found out, and then they say, oh yeah. If there is a time lag between the time of the injury and when they show up for medical care, that can be one of the indications of a perpetrator abusing someone. If they seem to control the person through threats when they're in the interview, they don't let them talk, or they say, no, that's not how it happened, and they take over the conversation. Those may be signs that some physical abuse is happening. Next slide, please. So with psychological abuse, now these types of abuse, of course, can cross. I'm so sorry that the sound is not allowing you to hear this.
Yeah, it just seems like there's a deep echo, like you're in a bit of a chamber. So I'm not sure what to suggest other than at this point.
Then in my office.
Yeah, just speaking up.
Yeah. So next is psychological abuse, and these forms of abuse and neglect often cross, and you'll see numerous types of symptoms. That's why I like to talk about the perpetrator's behavior as well as the victims, so that you have a good sense of what to be watching for with both the caregiver and the patient. So psychological abuse is the intentional infliction of mental harm or psychological distress. It also includes violation of basic rights. And that one was more recently added as well. If they are rights that are protected under the state and federal law, things like freedom of religion, freedom of privacy, freedom from discrimination, freedom of speech, the ability to engage in political events, the freedom to have one's friends and family visit them, those types of things. Those are violations of basic rights. Some of the indicators are that the victim behaves very frightened. They are careful about their behavior. They are depressed. They might be very suicidal. They might say that there is no support for them outside of this person that's with them. They have no friends. They have no family. They have no church. They have no other people in their lives. Yes, good question from Caroline. We'll talk about that a little bit later as well. And the perpetrator's behavior can be things like withholding the person's mail, never letting them read their own mail, restricting their religious practices or their folks from church or tabernacle or temple that might want to come and visit them. Isolating from friends, being isolated from friends, not isolating themselves, but there's that too. They might be afraid to tell people what is happening because they're afraid they'll get in trouble from the abuser. I've seen things like removing doors from a person's room or padlocking people in. And sometimes it's a case that they know that this is wrong, padlocking somebody into their room, and sometimes they don't. They're doing the best they can. Again, this is a situation, unintentional harm, and we'll talk about that more in a minute. They might be giving them less medication than they're supposed to take, or more medication than they're supposed to take, and kind of zonking them out. Psychological abuse. Another thing that folks may do is threaten harm to the person, threaten harm to their pet. And in Mrs. A's case, she has her beloved dog Killer, and that could possibly be a reason that she might do what her abuser would say, because she's afraid of the dog getting hurt. I know I have cats, and if somebody threatened to kill my cats, I would probably do whatever they wanted. Also, we hear frequently the threat to send somebody to the nursing home. If you don't do this and such or give me your money, I will send you to a nursing home. Also, destroying people's belongings, threatening to get them declared incompetent. All of those things can be psychologically abusive. Next slide. So I wanted to show you this picture because this is a real case. This was a patient of mine that this occurred to, and it was in the Seattle Times in 2013. A woman who was a physician and a very stressed, burdened caregiver for her older adult parents who both were diagnosed with dementia, and they were wandering at night, getting up and wandering. So her boyfriend made a cage that would be put over their bed, and they would be locked in at night. They couldn't get out. This was only discovered when we, in the primary care clinic, ordered home health to go in. And the home health worker saw this contraction and immediately called 911 and APS. And we were stunned. This was a case of a caregiver who'd been caring for her parents for a very long time. She was a physician, a practicing physician, and we had no idea. The parents always looked well taken care of. They didn't speak very much English, so they couldn't talk to us very much themselves, generally, from the beginning. But it was a shocking discovery that this had been happening. We don't even know for how long. And it was only because somebody saw it that it was discovered. So this case has taught me a lot. This was probably 15, 16 years ago now. Well, maybe not that long, but a while ago. And so now I do tend to ask better questions. And if in doubt, send in caregivers from home health or skilled home care. They can be another set of eyes on a situation if you don't have very good eyes on, or if you suspect something. This is a good idea to check out. Next slide, please. So sexual abuse is any sexual activity that the person does not or cannot give consent. And now we also are including trafficking in sexual abuse. And indicators of this obviously are physical signs of sexual assault, infections, poor hygiene, especially in the genital region, somebody not wanting to be touched, having an exaggerated startle, avoidance of eye contact, not wanting to be seen, suddenly wearing a lot of clothes, or suddenly wearing very different clothes, acting provocatively for a new behavior, and generally fearful. A perpetrator might do things like obsessively touch the person, not want to be very far away from them, wanting to have one hand on them all the time, controlling type of touch, firm, making comments about the person's body, especially in front of someone else, to shame them or to embarrass them. Again, removal of doors on a person's room so that they can't dress in private, can't take care of themselves in private, can't go to the bathroom in private. Those types of things might indicate sexual abuse. Next slide, please. For material or financial abuse, as I mentioned, this is the one that I see most often. And this shows up very often with the veteran not knowing very much about their finances, not knowing what bank their money is in, not knowing how much money they have, not knowing the last time they had access to their own money, not having a card to get money out of an ATM, not being allowed to ever have money in their pocket, always having to have their money monitored by someone else, when they do not seem to be having cognitive impairment to the degree that that would be required. If they're living below their means, this one happens, has happened in my caseload. Folks suddenly not being able to buy enough food, suddenly losing weight, their clothes raggedy, and not being able to buy new clothes or appropriate clothes for the weather, boots, shoes. They'll say they don't have any money when you know that they're getting a pension or a Social Security benefit, and they should be able to afford those types of things. If they're very, very frightened or anxious about spending money, that might indicate that there's something going on with their money. Going to a withdrawal, quick withdrawal place, like Western Union or those other types of places. Sometimes folks will have somebody who has cognitive impairment go to the same quick money place multiple times a day because the person doesn't remember that they've been there once already and got a bunch of money out, either of the bank or a quick money place. I've had the quick money places actually call family members and say, we are worried about this person. They've been to the bank 3 times today and they don't seem to remember that they've taken this amount of money, and there was this person with them they were giving money to. The perpetrator behavior is often bringing documents to you to sign. Sign new power of attorney documents, sign documents saying that they no longer can manage their own finances, sign documents for an attorney, or trying to get guardianship on a person that may not appear that they actually need a guardian. If they are focused on the person's money, if they are switching accounts all the time and the person doesn't know why, those things might indicate there's something untoward going on at this point. Next slide. I include scams and frauds in here because I do a lot of trainings about scams and frauds for older adults. And they just get more and more complex, more clever, more exploitative, seems like by the day. There are many different types of scams. We are the hub in the Seattle area for a lot of very organized scam groups where they have conference rooms and they train how to get money out of people on the phone, how to scam older adults. There are rings of folks doing sweetheart scams, pretending to meet an older gentleman in the parking lot of a grocery store, helping him to push his cart, kind of befriending him, and then over time bilking him out of all of his belongings that are worth anything, the deed to his house, emptying the bank accounts, under the guise of they're in a relationship with this person, and the victim often feels embarrassed, doesn't want to tell anybody in the family or any friends that this is happening because they're afraid that they will think that they can't manage their own affairs anymore. There are lottery scams, there are the sweepstakes scams. There are folks that will walk up to somebody's house and say, it looks like your driveway or your roof needs to be repaired. They'll get into the house by, asking to use the bathroom and then steal their belongings. There's the IRS and Social Security scams where I get these about 3 times a week myself. They call on my desk phone, which is very strange, and tell me that I need to give somebody money or they're going to come arrest me in 20 minutes. There's new ones now when the recent snow happened, all kinds of scams around, we'll come and make your house weatherproof and do all kinds of things. And there are many, many of them. So I like to educate older adults because they are targeted. They are targeted as veterans. They are targeted as people over certain ages. They are targeted on Medicare lists that have been purchased. They're targeted in every which way. But the Federal Trade Commission and AARP have a lot of good information about this. And they also, on Federal Trade Commission, they can talk a person through reporting it. And they are investigating them, and they are bringing some of these folks down, but they pop right back up again. They're very crafty and awful. So I'd like to educate everyone and family members about this too, because even my mother got hit. She has no cognitive impairment whatsoever, and they bilked her out of $1,000 to quote unquote repair her computer, put a virus on it, took money out of her account. So they're everywhere. So next slide, please. Next slide. Can you hear me?
Yeah, I moved it forward. Did you want the next one after that?
Yeah, there we go.
Okay.
So who are these people? We've talked a lot about family. We've talked about paid caregivers. The perpetrators are most often male. They most often have some kind of health problem or disability, substance abuse, depression, anxiety, impaired mobility. Often they have a history of trouble with the police. Often they are socially isolated. They may not have a support system of their own. They don't have friends and family. They stay in the house a lot. They may be underemployed, unemployed, having financial problems. This is definitely coming to the fore during COVID. And they're often experiencing major stress from the situation at the house, at the loved one's house, or in their personal life. Next slide. So some of the contributors to abuse, neglect, and exploitation, inadequate coping skills is definitely showing up in that unintentional neglect. The person doesn't have access to resources, or they don't know about them. They don't know who to call. They don't know who to ask for help, or they don't have anyone. Don't have any people in their lives, or they're afraid that if they do tell someone, they'll get in trouble, they'll get arrested, they'll be made to do things that they don't want to do. They feel like they don't have any options. They may be in a rural area where there's less resources. And the interesting piece is that as the dependency between the victim and the perpetrator increases, so does the resentment of being in that role, being dependent upon the person. They may be living in the victim's home. They may be driving the victim's car. The victim may be giving them their money for their spending money. They may feel like they're completely trapped in this situation and resenting this dependency state. Also, the research indicates that there is entitlement thinking patterns, a desire to exert and maintain power and control. They're helpless. They want to get that power back. So they want to control someone else in order to do it. They're not controlling their own situation, their own life, and so they want to control someone else. Also, there's an interesting theory about intergenerational transmission of violence. that the formerly abused person is now the caregiver, and they have a chance to pay back some of the abuse that they might have received as a child, as a young adult, and they have this opportunity now where they're in control. This shows up, the same dynamic shows up in domestic violence, interpersonal violence. Next slide, please. The wheel here I included because it is the wheel that was originally created for the domestic violence field. And this here has been adapted by the Domestic Abuse Intervention Project to include elder abuse. And this is modified from that other wheel for domestic violence. So now you can see kind of all of the elements that go into creating this dynamic. The ridiculing of values, the manipulation, the intentional isolation that can occur, the threats, intimidation, control, all of these things showing up in how they interact with each other and create this abuse situation. Next slide, please. Culture and abuse. So the societal attitudes and belief systems in other cultures can also set the stage for abuse to occur and for abuse to not be reported and not be discovered. We are in a culture where older adults are often thought to be a drain on the resources, costing a lot. We should just get rid of Medicare. It's only for old people. The lack of respect and the resentment of having to take extra time with an older person who might need extra help. It might be slower than everyone else. So this kind of pervasive attitude can create that situation where abuse can occur. Basic rights not honored, or people not labeling what is occurring as abuse. Oh, they're taking care of the person and they're a little rough. Well, it's because the person needs them to be rough, needs them to move them abruptly because they won't cooperate. All of those things that people say to themselves when they're crossing the line from care into abuse. What is considered abuse can vary across different communities. So you might see things that go on, say, in a religious practice that might be abusive or appear to be abusive. We have seen this show up in school systems where children have participated in religious ceremonies that have left marks on the skin, and teachers have seen those marks and reported that to Child Protective Services. There's also a situation where what goes on in the family is said to be private. Everything that goes on in this house shouldn't be talked about with anyone else. A person might be in a situation where that shame and that embarrassment keeps them from revealing what's happening. There might be language and cultural barriers that prevent the person from talking about it, like the parents in the cage. They did not speak English fluently and spoke only the language of their abuser, and the clinicians were not speaking that language, and so there was a lot of difficulty with anybody even being able to be told. Next slide, please. So this is my newest slide, accommodating what's happening during COVID. I did some searching around King County and also across the country to see what kind of research is popping up around abuse and neglect and exploitation. And the issues tend to be similar. New York was the first one to start doing research on this, and you can see the studies down below in the reference. The COVID has done a couple of things. It has caused people to be with their family and caregivers more often without a break. It has caused the normal social monitoring systems to not be in place. So APS is not doing visits face-to-face in a lot of places. Social workers are working from home and not seeing people face-to-face. Police are refusing to go out when they're called on a 911 call, especially if the person is COVID positive. Courts have not been in session, so the vulnerable adult protective orders that we'll talk about in a few minutes have not been happening. Long-term care facilities are not taking folks for respite, for placement, to provide respite to the family and caregivers. And so that has caused the family to go long periods without a break. And the care has changed. So there's less staff that are providing the care. Home health workers, the agencies are understaffed. They're not going in and providing care and relieving the stress on the in-home care, the family members, and also relieving them. The video visits and the phone visits are not a long-term solution to be able to assess folks that really just need to be seen face-to-face. Because of the financial situation that has occurred because of COVID, the family members are under more stress. They have less access to stress management activities. Family members can't go and engage in their normal stress management activities, and the victims can't leave the house either. They can't go to adult day health centers and do something fun and engage with somebody other than their family. Also, the stimulus checks are fodder for those scammers to try to exploit, and getting those out of the hands of everyone, really, but definitely out of the hands of older adults. Next slide, please. So now we'll talk about assessment. Well, what are the barriers to assessment? Somebody mentioned the comment, I believe it was Caroline, about what happens if the person is having mental health symptoms or psychotic symptoms. How do we assess people in those situations? That is definitely a very good question. And that is one of a myriad of questions that I hear. Is this really my job? Am I the one who's responsible to do this? How much time will it take? I don't have time enough to sit with this person who has cognitive impairment. Well, I don't know what questions to ask. I don't even know where to begin to assess. If I start asking all these personal questions, want to defend the person, want to defend the caregiver, there's not enough space to interview the person alone. And what if they want to be with their caregiver and I'm worried that they might be abused by their caregiver? You can't assess a person with dementia or with mental illness. Shouldn't they have a cognitive evaluation or a mental health assessment done first? Shouldn't they have a mini-cog or a slums test to determine their score? Doesn't a dementia diagnosis mean that she's not competent? You can't assess somebody who's not competent. We can't believe her. She's experiencing hallucinations and paranoia. We can't believe her. Whatever she says is not going to be true. I don't want to report this because I'm afraid that their rights will be violated. They won't be able to own a gun. They won't be able to do other things that they might do now, and I would be afraid that I would be the one to do that. And my favorite, abuse is rare. It's probably just a physical problem. If I had $1 for the time I've heard these comments, and addressing these things and making it expected and making it possible and easier to do is the way to go. To get this education, to start working on implementing programs within your systems, to make sure that it's possible to do these types of assessments, and that there's support to do them, and that there's resources to do them. Next slide, please. So in terms of assessing and documenting, documentation is really very important for this topic, because if there's going to be any kind of interventions by Adult Protective Services, they're going to need medical records and documentation. Some of the symptoms and indicators that we talked about, it's very helpful if those exist, and to be as clear and accurate as possible when you get this information. It really should be the person who hears the information first that documents the information. It does the assessment and documents the information and does the reporting. Very important. Often I used to get called by physicians and nurses in departments that would say, well, social work's the one that does this, right? We have subsequently we have instigated processes so that people have been educated about how to report and what will happen when you report, and everyone is a mandated reporter in a medical system. So anyone who hears this information should be able to report. Most important thing is to really look at the person. What is their appearance? What is their behavior? What are they doing? And documenting. Getting as many details, names, contact telephone numbers, emails, assess the understanding of the victim of their situation. Why are they in the emergency room? Why do they have bruises on their wrist? Why are they acting so afraid? What is it that they're afraid of? Simple questions. Even if somebody is having psychotic symptoms, they can be assessed. And it's a matter of knowing what the person's baseline is, being able to say this is very different from how they behaved before. This is the evidence that we have. When we try to touch them, they have a very exaggerated startle, and they haven't had that before, even when they've had these maybe psychotic symptoms before. So that documentation becomes very, very important for the current situation, but also for the future. If this happens again, it's building that paper trail to be able to do more interventions. Assessing when you have the opportunity to see this person, assessing if it is safe for them to talk to you. Some people have been told if they talk to anyone, they will be punished in some way. And is it safe for them to return home today? They might not be able to return home, and they may need an intervention right straight from the emergency room or clinic. Assessing any change in their daily activities and the instrumental daily activities. A person who has been experiencing new abuse may suddenly stop doing things for themselves or doing things differently. Assessing access. Do they have access to any resources in their community? If they're living out in the tule bushes, where can they go? Is there a place that they can get respite or that they can stay for a while if they need it? Assessing the finances. Do they have money to pay for some kind of intervention, in-home care, a stay at a nursing facility, a caregiver to come in from an agency? Or do they need a fiduciary or payee to manage their money? And sometimes, if it is safe, you can talk to the person who you suspect of abuse. If the person appears to be safe, meaning that they may be doing something like the families, actually this has occurred 3 times, that were locking their loved one in with a padlock at night in their bedroom. And when I told them that that was considered imprisonment, they were stunned. Had no idea that this was considered abuse, and immediately rectified the situation. Were very open to having paid caregivers come in. Were very open to having follow-up and counseling around caregiver stress. They really just didn't know better, that this was not the way to go about protecting their loved one. And they stopped. So the appearance of impropriety conversation can work in some circumstances, but the safety of the victim is the most critical. And the type of abuse also is critical. If they're severely physically abused, they may not be safe, or sexually abused, they may not be safe for anyone to have that kind of conversation with them, except maybe the police security could be reported in that way. Next slide, please. So the assessment with someone with cognitive impairment does get trickier, but again, you're building a case. So you're taking the evidence that you see by what you're observing, by the questions you're asking, by how they react to certain things, by what you know of them and their baseline, by the progression of their disease. Have they reported these things in the past and now they're reporting them again? Have they had cognitive testing? Have they had a decisional capacity evaluation to see whether or not they really can make decisions, whether they really are understanding what they're being asked? Can they rephrase what you say to them in a way that demonstrates that they understand what you're asking them? Can they say it in their own words? Can they tell you in a way that is not a clinical repetition of what they've been through? Are they able to manage other types of decision making? Are they able to manage taking care of some things at home? Are they demonstrating judgment? Are they able to say, this is wrong, this is not wrong? Are they able to say what they would do in an emergency? And also using the people that they trust, if there are other people in their life or on their quote unquote team, other family members, people from their church, people, neighbors who they trust. Can those people talk to them and find out information that they might be reluctant to tell you as a clinician in this type of clinical setting? Can you move them to a different kind of environment where they might be more likely to be able to give you accurate and cogent information Maybe it's too loud. Maybe it's an emergency room where a million things are going on. Maybe it's a room that's very bright and overstimulating. Maybe in a smaller room, they'd actually be able to talk, willing to talk about what's really going on. Next slide, please. So all of this culminates in how, of course, do we intervene and prevent. The reason I do these trainings is just to get people familiar with asking these questions, knowing what questions to ask, knowing the signs, planning in advance for things that might come up, planning for a plan to give the caregiver respite. If you have a spouse that is taking on more and more and more caregiving, eventually there's going to need to be in-home care. Starting to take a look at what are the finances that will support, that will support that. What are the resources that person can bring in? Do they have friends? Do they have church? What do they have? Looking at multidisciplinary collaboration and treatment. Pulling in social workers from other settings if they're going to adult day health programs. There's a social worker there that you can bring into the team to help this person be less at risk. Are they depressed? Are they anxious? Are they needing mental health treatment, substance abuse treatment, either the victim or the caregiver? And doing more research. So we can get answers to some of these questions and develop interventions that are helpful. Next slide, please. I've talked about respite. Respite can be provided in many different ways, and we often cobble things together to provide some support for the family members and caregivers. Respite is provided at the VA in certain circumstances, in home and in facilities in the community like nursing homes. Some senior services in the community, paid for by county or city or faith groups. They also have services that could be used as respite. Stays in nursing homes, assisted livings, adult family homes, those can be paid for privately if there isn't someone else like the VA who might pay for them. There are usually local crisis services in every city, and those sometimes have some monies that can be used for respite. There are community agencies, like in Seattle, there's one called Lifespan Respite. There are community centers that might have programs for caregivers to educate them. They might have activities for the victim to engage in to provide some time away from the caregiver. Even things like I've had veterans whose wife was very stressed, but the veteran was still able to go to the gym. That was one thing he's been doing for 40 years. He does it the same way every day. He was able to walk the 3 blocks to the gym and back all by himself, although he was diagnosed with dementia. But that 2 hours was enough to give the wife time to take a bath, read a book, and relax. That was enough 3 times a week to keep her stress level managed. Making arrangements with families to have regular respite, a certain number of hours, certain days of the week is really helpful. Next slide. Powers of attorney. Powers of attorney that can designate people to make decisions regarding estate, management of money, and also of daily activities, where a person might live, etc. Those healthcare powers of attorney don't require an attorney. Those things can also be talked about more with social workers. They can be experts in trying to get these resources set up for patients. Next slide, please. The vulnerable adult protective order I mentioned in connection with the courts earlier, they will protect folks from abandonment, abuse, and isolation. They're similar to a no contact order, but for vulnerable adults. The petition may be brought to the court by any interested person who feels like they have some interest in the care of this person. The victim, if they are unable to protect their own interests, if they are vulnerable, if they meet the vulnerable adult statute. And permission from the victim is not necessary to file one of these. It goes before a judge. The judge makes the determination as to whether this is granted, and it can last up to 5 years. Next slide, please. I'm going to roll through a little fast. Guardianship. The two things I want you to know is that guardian costs money. Most of the time it does. And so it can be a little bit of a struggle to go through the process to get a guardian if it is a patient that doesn't have any, doesn't have much of an estate. It can also take a long time. It can take up to 6 months to get a guardianship in place. And the guardian cannot place a person into a nursing home or psychiatric facility without a judge saying so. A guardian can't do it. Even if they've been placed by the court, they still can't do that. And that is often the thing that people want guardians to do. And they really just do that. There are lots of ways to help people be willing to go to facilities, and social workers are great in talking about those things. Next slide. Mandatory reporters. As I said, if you suspect abuse, neglect, exploitation, report to the APS and to the police. If you think a crime has been committed, or a weapon's been involved, or there's been threats for physical violence, sexual violence, report to the police as well. All of us who are clinicians are mandated reporters. And Christian Science practitioners are also now included in this list. If in doubt, report. Next slide, please. Steps to report. Call 911 if the person is in immediate danger. Call Adult Protective Services. If they are living in their own homes, sometimes depending on the state, they'll have another service like an ombud service or a residential care service if they're living in a facility that's licensed by the state. In Washington, it's called residential care services. So if they're living in a nursing home, adult family home, assisted living, boarding house, memory care, those get reported to the residential care services. They do investigate very similarly to adult protective services. Next slide. After the report is made, then APS starts an investigation if the person is in fact a vulnerable adult. And they may do a number of things to initiate help for the person. They may assign a case manager. They may offer them various resources. Some of those resources might actually have a fee attached. And law enforcement, of course, might be involved. If they are in immediate danger, they can do an immediate protective services and have the person removed from the home if there's immediate harm happening. And they can also help get the vulnerable adult protective order. The one thing to know is that a vulnerable adult still has the right to make their own choice when they're offered whatever adult protective services might offer them. They can refuse to let adult protective services in the house. They can change their mind and withdraw consent. That is still possible. Next slide. And then I included in these slides some other people, other agencies to contact. I included the national resources and a few Washington resources as well. I know some people might be in other places. But that will get you started on other possibilities for interventions. I know there's some folks that wanted to have some time for some questions, so I will stop and let that happen.
Okay, Barb here, just catching up. Let's see, we have a question from Rose who asks, are there more stringent pre-screening or screening for caregivers? The FBI has a screening before becoming an agent. If there is such pre-screening, are there any studies that look at the efficacy of a pre-screening tool for caregivers?
There are some screening tools depending on who is vetting the person. If it's the state looks at their criminal record. They require them to do a certain number of hours of training. I believe it's 27. They require them to do trainings every year, certain specific topics, dementia, agitation, things like that. The homeowners, the adult family homeowners are required to go through a certain amount of training. Private pay caregivers, if they are affiliated with an agency, but they run their own schedule and all of that, those have some screening. If you just have a person out there who has decided to be a caregiver and is willing to take $15 an hour to do it, which is far below the market rate, they wouldn't have any screening. That would be incumbent upon the person who is hiring them to do a background check and do that kind of thing.
And then I think you answered some of Caroline's question, but I'm going to pose it again. What about paranoia, hallucinations, and delusions with regard to abuse?
Right. So it's really important to know the patient and know what their normal baseline behavior is like when they are having episodes and when they're not. If this has been a patient that you've known for a while, and getting information from other people about what is their baseline. Just because somebody is paranoid doesn't mean somebody's not out to get them. And you can ask in certain ways that can get to that by asking them to explain or show you what is happening. Get the evidence from other places, the apartment manager, the neighbor who's been helping this person. Have the person in for a cognitive evaluation, a slums. Have them, have their gas revisited. Are they taking their meds? There's lots of ways to sort of get around the issue. In the meantime, report. While you're collecting evidence, if you suspect it, report it. Get the evidence after that. You want to make sure the person is reported and that you're trying to intervene to the best of your ability ASAP. But I've had lots and lots of my previous career before the VA was in the mental health world. I've had lots and lots of patients with comorbid mental health conditions that are being abused or exploited just because they might also be paranoid. Doesn't necessarily mean it's not happening.
How do you, or would you suggest differentiating domestic abuse and adult abuse in older adults?
Well, depending on when it started, that might give you a key. At the end of the day, it doesn't matter which it is, it's abuse. If they are a vulnerable adult, they meet the criteria, and it's been long-term domestic violence, and now they're an older adult, it's now elder abuse. It doesn't matter. It still needs to be reported and intervened on. But you can get that information, you can get that, what has their life been like? Have they been living with this for 40 years? Are they unsafe to go home? If they're unsafe to go home, they're unsafe to go home, regardless of who it is that's doing the abuse. The long-term abuse is sometimes tricky because they've developed very well-worn ways to keep other people from knowing about it and to keep themselves from getting more harmed. And so it can require much more trust. It can require bringing in other members of their family or other members, friends, church, ministers, whoever else might be somebody they trust and would talk to. It also could be that their cognition has slid, and now they're not able to protect themselves like they used to because they don't have the cognitive bandwidth to do it anymore. And that becomes much, much harder. And it is very common for somebody who's been abused for 40 years to continue to be abused once their cognition declines. Very sad, very sad. But we need to intervene to the best of our ability.
What are your suggestions for finding guardians for Medicaid recipients? Is there a simple resource that could be dog-eared?
Oh, if there only was. What I've done before is gotten attorneys that were fresh out of the bar and they wanted the experience doing guardianships. And so they've taken a case on basically without pay, pro bono, because they just wanted to learn the process and know the process. It is hard to find it for folks who don't have an estate. If they're in a hospital like Harborview has a nice process that they've developed with the Attorney General that can get people without estates guardians. So if they ever happen to be in the hospital, sometimes that's easier. If you have attorneys that work with people of specific types, like we used to have a lawyer who was a veteran, and he would take on guardianship cases because he was sort of dedicated to veterans. He has subsequently passed away. We at the VA have a sort of a system now for the patients, certain patients inpatient in the hospital, but not for outpatients. It's really tricky. If you find a good attorney who's willing to do it, you want to hold on to that person and give them chocolate, you know. No, I'm not suggesting bribery. But yeah, it's hard. It is really, really hard to do. If you find a way, please send me an email. I would love to know any attorneys out there who will do this for no money.
Well, I can say it doesn't necessarily have to be an attorney. There are professional guardians, but the finances in terms of Medicaid is an issue to get worked out.
Right. Well, the guardianship has to be started by an attorney. If you can't get the guardianship started, doesn't matter. But if you can find an attorney that will do it and walk it through the court process, then you have to find the guardian themselves. And
that's true.
That is equally as hard.
Yeah.
Equally as hard. And there are a few people, I'm on the board, or not the board, but I get all the emails from the guardianship board. And there are some people out there that, you know, hold one or two people that don't have enough money because they were a social worker, or they were a guardian ad litem, and they have, you know, they've dedicated themselves to these populations. But
so Rose is wondering if there is prevalence of abuse associated with specific ethnic or cultural groups. I think she's asking if about particular kinds of abuse. What are the ethnic cultural groups we see with abuse coming with, I'm not sure I'm reading this right. In some cases, gender or gender identity matters and may influence the way care is given. And so is there particular types of abuse that people from specific ethnic cultural groups or gender identities may experience? I hope I'm reading that right, Rose.
I think I understand it, Rose. That's a great question. Yes, there is some research out there about specific populations. I knew I didn't have time to really go into that here. So I have not taken that topic on too much in my research, but yes, there is. Certain population, transgender has a very high violence. Research indicates lots of violence for the transgender, and I imagine, now this is anecdotal, I don't know, but I imagine that the research would bear out that continues once they are older adults as well. Poverty certainly has a significant effect on families, and there are certain cultures that have very high levels of poverty. And I imagine that you would find that in the research, that there would be some research about that. I am not an expert on that, though. I haven't done a search for that specific data on specific populations.
So, Kris, we're at a little bit after 5:30. How are you doing for time? I can pose a couple of questions and then send you the rest of them to maybe respond by email.
Yeah, I can stay as long as people want to ask.
Okay. So what are your suggestions for, let's see, please reiterate if VAPO is a national law or state by state?
Some states have it, and some states don't. You'd have to look for your state. We've had it in Washington for a long time. A long time. So some states do and some states don't. The fortunate thing about our state is that we have a very dedicated Attorney General and Prosecutor's Office that really has coalesced around elder abuse and has an elder abuse team, and they prosecute. The team has been a leader in our community for trainings. They hold an elder abuse conference. If you're in Seattle, you want to go to that. If you ever get the opportunity, it's fantastic. Usually it's held every year. And it's put on by the Attorney General's office. And so different states have different foci in how they are handling and prosecuting issues. But it's moving across the country. More states are participating in the larger conversation about developing teams and expertise on this issue and educating police and educating banks and educating. We've done a lot of that here in Washington State. So bank managers are gatekeepers. They will report to the police and the APS if they see signs of abuse. It's fantastic in this state. So look up in your city government and see, and your police departments, if there is anything happening in your state.
So Alex says, I'm an RN in internal medicine, primary care, and we don't have an MSW on staff. I take care of all the APS referrals and talking with the APS investigators, collaborating with home health services. I've found that reporting APS concerns over the online website is most efficient. I've done it over the phone and have found that takes much longer. I didn't see the website listed on your resources, and so Alex posted the Washington DSHS website for, and I'm not sure everybody can see this, so I'm going to post it into the chat box.
Okay, great. Yeah, I put the national one and 1-800-END-HARM, which, in the, I can't see my slide now, but there is a website listed on there, and you can easily find it. If you do go to the phone line, I report on the phone primarily because I want to ask them, when they take the report, I want to ask them who the investigator is going to be. And then I document that in the record, and then that allows me to connect with that person after the investigation has begun. And then I can find out if they substantiate or not. Because they don't always tell you, they won't always call you. But if you're the one who makes the report and you call them, they will generally tell you if it's been substantiated or not. And you can collaborate with them in getting doctors' documentation and other records and things like that too. That's why I do the phone.
Okay, and Erica says in a retirement community, there are often individuals who work with or prey on independent residents who don't have POAs. What might be the responsibility of the community to interfere with a helper that gains trust and assists or takes over decisions for finance or healthcare? Nothing reaching the level of APS, but it's still very suspicious.
Well, if they are exploiting them in some way, it would reach APS. And, you know, if you think that there's something untoward going on, like touching and things like that, that certainly would be a police report for assault. I'm not exactly sure what you mean is happening, but if they are gaining their trust and little by little starting to take over their lives, that definitely would be psychological abuse. So yes, I would say report it. If in doubt, report. You know, as many people who can lay eyes on that person and be involved in their care, it might help that person feel less able to do what they've been doing if more people are watching.
And last question, can you speak a little more about what can be done for an older adult who is neglecting their own care? Maybe has been hospitalized several times in 1 year due to self-neglect. I'm thinking of someone who had a demonstrated reduction in decisional capacity, but continues to test fairly high in standard tests.
Yeah, self-neglect is so hard. I think self-neglect often comes down to building trust with the person. Or finding someone else who they trust. Doing a lot of work around choice and giving them choices that are less harmful to them. So starting small and doing baby steps to get other people into their house, to get people delivering food to them through Meals on Wheels, to you know, get control of their money for Social Security through a payee, or little steps, getting the daughter who hasn't seen them in a long time start to visit. If they have positive feelings towards the daughter, but she hasn't been there for a long time and isn't aware of what's going on, and the patient wants them to come visit, you know. Little baby steps, I think, is the thing that it takes. And even people like mail delivery people can be those people who are the grocery store clerk, know the person, see the person, they somehow trust them. Trying to bring those people in, get the person to, you know, whatever it is, have them suggest something because they trust them, but they don't trust you. You know, so maybe they'd allow you to talk to them and then they can suggest something, you know, just any little way that you can. It's so hard. Often doctors are critical in getting people seen. Maybe a hospitalization We can do geriatric evaluation and management at the VA, although we haven't been able to during COVID, but in normal times, bringing somebody in to have a geriatric evaluation in the community living center, get some other eyes on the person, you know, under the guise of, hey, come into the hospital. It's just like being in a hotel. People will bring you your food. You can watch TV. Hey, it'll be great. And then once they get here, then, you know, more people take a look at their skin, and they get seen by a nutritionist, and they get a dental appointment. You know, some of those things happen. So just any way possible, baby steps. Please
All right.
email me or call me. I'm happy to talk with you separately as well.
So I just want to thank everyone, including Kris Fredrickson, for putting up with the audio glitches and hanging in there with us. This was a great and incredibly comprehensive talk. We really appreciate it. We will see you next week, and we will send out information about continuing education and more information coming up about the spring series coming up towards the end of March. So see you next week.
Thank you, everyone.
Thanks so much, Kris.
Bye.